Welcome back, everyone. We're going to start where we left off, we're still talking about hemoglobin. And we've been discussing different point of care testing devices that can be used in a patient's home, at their bedside, in a small physician's office laboratory. And so we'll pick up here. So the question that you see there is, what are the common principles of the hemoglobin test? Okay, so the principles are about collecting blood into the appropriate testing device. This is the Hemocure that you see in this picture. It's also in your textbook. And if you'll notice in the second picture, right here, okay, you'll see right here, this is a specific cuvette. Lack of a better word, another little instrument that used to collect that specimen, right? And if you'll notice right there, the patient's finger has been pricked, and they wiped away that first drop of blood, and then they pressed on the finger to get a big pregnant drop of blood there. Then they took this specific cuvette that is used with the Hemocure, and they touched the tip of that Hemocure cuvette to that drop of blood, and through capillary attraction or action, it drew that blood into that cuvette, and it will stop drawing when it's full. Then as you see down below it, down here, okay, let me erase that off. I got that a little bit in the way there, okay. So, but we, as you can see down here, it then is placed inside the Hemocure instrument, handheld instrument. And then what happens is there's a light source inside the machine, and it shines a light through that blood at the end of that cuvette. And an optical reader receives the light on the other side as it passes through the specimen, allowing it to calculate the amount of hemoglobin that is in that specific specimen. The instrument then produces a digital readout expressed in grams per deciliter. And if you'll notice in that picture on the top, the Hemocure picture at the top, 12.5 milligrams per deciliter, that would have been the hemoglobin reading for that patient. So this is how that's done. And moving on, still talking about hemoglobin, and HGB is the abbreviation for hemoglobin. We're talking about clear wave instruments commonly used by laboratory assistants, medical assistants, in satellite labs, in physician office labs, also sometimes in large hospitals through home health agencies that does hemoglobin testing at the bedside or at their home. This particular model that you see in this picture is an iStat point of care. And if you'll notice, again, we see that this instrument has a very specific cuvette that goes with it, and this instrument would also be used to collect the blood, and then you place that cuvette in the instrument, and it works on the same basis. Okay, so which abnormal condition is the hematocrit test used for? Okay, so we were talking about hemoglobin, right? And we talked about how hemoglobin is a test that helps us with the anemia. And the same is true for hematocrit. That's why you see those tests go hand in hand, hemoglobins and hematocrits. So what is the principle of the microhematocrit test? Okay, it measures the percentage of packed red blood cells that results after centrifugation. Okay, so if you see this little instrument down here at the bottom, okay, which we have one in our lab, and I know you guys have seen it. Some of you have used it in the lab. You do your finger stick on your patient, and then you collect your microhematocrit tubes. Okay, and then you put your clay in the bottom of them, right here. This is your clay to seal them. Then you place the clay end down, and here's the clay down here at the bottom, okay? The clay end down in that centrifuge, okay? And then of course, you have to make sure they're balanced. Then you spin them down, and then the reading apparatus is down here. And what you're doing is you're looking for packed cells, okay? And then there's the right here's the packed cells, okay? And then you'll have your plasma, okay? And so what it does is it measures the amount of these packed cells that's down there, okay? So after you centrifuge it, you compare the volume of packed cells to the total volume of the measured specimen. So the complete specimen, which would include, if it's an heparinized microhematocrit tube, then you would count everything from the beginning of the packed cells all the way down to the plasma, okay? And RBCs occupy almost 50% of the total volume. So that's what you're looking for. And when you see these results where you would see very few packed red cells, that usually tells you that the patient is anemic, okay? You can usually see it when you take that specimen of the centrifuge. So how does the numeric value of the hematocrit test and the RBC compare to the numeric value of the hemoglobin test? The hematocrit value is approximately 3 times the value of the hemoglobin. The rule 3 equals and divided by 3. To compare hematocrit results with hemoglobin and RBC, the RBC times 3 usually equals the hemoglobin, and the hemoglobin times 3 equals the hematocrit. In other words, if you have 4 million on your RBC, your hemoglobin is going to be 12 milligrams per deciliter, and your hematocrit is going to be 36, okay? So if the hemoglobin is 12 milligrams per deciliter, what would be the approximate value of the hematocrit? So what I'd like you guys to do is pause this video, take out a piece of paper, do the math on this, and then tell me what you get. So it's going to be 36%. Because 12 times 3 is 36, right? Okay, now next, what would the approximate RBC be? 4 million, okay? So now, an individual from the reference lab calls to see if you perform any wave test for anemia in your POL. What is a wave test? Again, the benefit of watching these videos is that you can pause them, take out a piece of paper, and all through these slides, any of these questions or critical thinking, higher learning activities, you guys can write down your answer and just see if you're starting to put all this stuff together and answer these questions, because that will help you know what to study, what you're doing really well on, and what you may need to go back and study on so that you can be successful when you take the test. So a wave test is the lowest level and simplest of the 3 levels CLIA categorizes all laboratory tests into. So what are the 2 wave tests for anemia? It's the 2 we just talked about, right? Hemoglobin and hematocrit. Okay, so collect blood you want to be able to describe how to perform a microhematocrit test. And guys, really look in your textbook. They have a lot of good information in there. And putting all this together, watching these videos, filling out your study guides, reading your textbook, and referencing back thing to thing will really help you be very successful when you go to take this test. So when you describe this, it's like we talked about earlier. You collect that blood in 2 heparinized microhematocrit capillary tubes with no air bubbles, right? And we talked in lab about wicking that blood out onto your desk protector to get that blood back down near the end of that capillary tube and then continuing to collect your blood, right? You want to seal one end of each tube, and you have to have 2. You centrifuge those specimens, and remember, they have to be balanced in that centrifuge, and then you determine the percentage of RBC volume compared with the total blood volume by a built-in scale on this instrument, okay? Results of the 2 tubes should fall within 2% of each other, or the test would need to be repeated. So Still talking about the hematocrit test. The plasma of the spun hematocrit should be observed for which two interfering substances. And you'll see in this picture on the slide, the plasma is that yellowish looking substance there, right? Then you have your buffy coat, which is your white blood cells and your platelets, and then your red blood cells, and then at the bottom, the clay. Now, when you started measuring this, the instrument would tell you to take your line and move it to where the red cells meet the clay, right? Because we don't want to include that clay in our results. We want to measure from where the packed red cells start to where they meet the buffy coat, and then we'll measure from the buffy coat to the end, right? Now, when you spin it down, you really want to look at this plasma, because when we talked about shining light through things and all that, we want to make sure that this specimen is not hemolyzed, because if you collected your hemoglobin and your hematocrit with the same finger stick and you see that this plasma is hemolyzed, then very well your hemoglobin could have been hemolyzed, and it could have given out some possible erroneous results, because remember, we talked about that light shining through that specimen, and that hemolysis is going to change the color of that blood specimen and could give us some erroneous results, right? We also want to look for lipemia, where the plasma appears white and cloudy from high fat content. We need to note these things as we see them. Okay? So what you want to be able to label a spun microhematocrit tube. So again, one of the benefits of being able to do these slides at home and be able to watch this presentation at home is that you can pause this video. You can make sure when you start these videos, you can have you some paper out there so that you can do these little things there at home to test what you know, what you don't know, what you need to improve on. So we want to know that above that plasma is air, right? Then there's your plasma, then your buffy coat, and the buffy coat would probably be much, much smaller than what's shown on this picture, but they're making it bigger so that you'll really be able to see it. And that's your WBCs and platelets, because remember, there was heparin in that tube, and heparin is what? It's an anticoagulant, so the blood did not clot. Now, had there not been an anticoagulant in there, then there would be no buffy coat, because the platelets would have gotten all mixed up in there, and they're in that fibrin clot down in the bottom with the rest of those cells, okay? But in this, we do have plasma because it did have heparin in there. So you then would need to know that that's your red blood cell layer, and then down the bottom is your clay sealant, okay? So be able to label that. Again, another one of our higher learning activities. So my daughter Julie, this is a scenario like a case study, okay? So you say, my daughter Julie decided she wanted to become a vegetarian. I didn't think anything about it until she stuck with it for over 4 months. Then I began to worry that she might become anemic. I took her to the doctor. Which test could he order to see if Julie was anemic? A hemoglobin and a hematocrit. What type of collection container should be used to collect the blood if it is sent to a reference lab? The purple top tube. Okay, how should the blood be collected if doing a microhematocrit test in the POL? First, everybody remember what the POL is. It's a abbreviation for a physician's office lab, right? Okay. In 2 microhematocrit capillary tubes, and you always have to have 2, remember, and they have to fall within 2% of each other on their results. How would you know if she was anemic? Compare the results you get to the reference range for the hematocrit test. If in the POL, is it usually a CLIA wave test? Yes, if it is performed in a physician's office lab, it is usually a CLIA wave test. What is a waved test? A wave test is the lowest of the 3 levels CLIA categorizes all laboratory tests into. Okay, so the erythrocyte sedimentation rate, the ESR. So what is the principle behind the ESR, or the SED rate? It is the rate at which RBCs settle out, okay, of an anticoagulated blood specimen after 60 minutes or an hour, okay? So if you see right here, this is the picture shows the test, okay? So plasma proteins, especially globulins and fibrinogen, increase during inflammatory conditions, is what we're looking for, cause the RBCs to become sticky and stack together in a rouleau formation. And if you'll notice, that's kind of like coins stacking on top of one another, and you can see that right down here. That's what it looks like under the microscope. Okay? So like I said earlier, we're looking for inflammation, right? It's a non-specific screening test. In other words, it's not going to tell you what's causing the inflammation. It's just going to tell you if that patient has inflammation. And is autoimmune diseases, carcinoma, and leukemias, and other inflammatory diseases like arthritis can cause you to have increased inflammation, which would then in turn make your SED rate higher. So what other factors can affect the SED rate test, right? We want to know what other things can affect it. So size and shape of your RBCs, if they're not a normal shaped RBC and something's going on there, that could falsify your results or give you results that aren't really dealing with inflammation. If your blood is not fresh, okay, extreme temperatures, wherever that test is being performed at, technical factors such as tilting the test tube, vibrations, and allowing the tubes to sit over 1 hour, which increases the SED rate. And air bubbles in the tube lowers the SED rate. Okay, so how is the blood collected for the SED rate? Venous blood is drawn in a purple top tube filled 100% full. It can never be done by skin puncture. It requires way too much blood for that. So I'm going to go back one slide here. Oh, okay. Well, I guess I'm not. A long-time patient, we'll go on with this and then I'll explain what I wanted to talk to you guys about. Really what I wanted to go into was that SED rate, the tube down at the bottom is the tube that you put your blood into, okay? And it's filled up to a certain line, you put the cap on it, then you take that tube, that long tube that was sticking up, and you push it down all the way to the bottom of the little container down at the bottom, which makes the red cells go up to 0. And then you let it sit and you see how far down it's come, okay? And so most people, 0 to 20, but I have let it sit longer than an hour, which you should not do because it will give you inaccurate results. But I've done it just so people could see, because normally all the patients we had, our students that we had normal SED rates. So I wanted them to see what an abnormal one looked like. And so it really will fall down pretty far if you let it sit out there too long, okay? So on to our case study. A longtime patient, Mrs. Murphy, had lupus and autoimmune disease. What blood test could be run on her to monitor her condition? A SED rate. And again, SED rates don't diagnose patients. But if you end up diagnosing a patient with lupus or rheumatoid arthritis, and now you're medicating them, you want to find out if that medication is doing the job that it's supposed to do. One way you can do that is to do a SED rate on your patient, because if the medicine is decreasing the inflammation in your patient, which it should, then your SED rate should go down. And it shouldn't be as high as it was when you didn't know what she had and she had a lot of inflammation going on, okay? So what color top tube should be drawn? How full should it be? And what anticoagulant is in the tube? So we know, right? It's a purple top. It should be 100% full, right? And anticoagulant is EDTA. Okay? Is the test run in the physician's office lab, usually a CLIA wave test? Can blood be drawn by finger stick for this test? Remember, this is a good time to pause your video and be able to write your answers down to see if you're getting this stuff and what should you study more and what have you already learned. Yes, it can be run in physician's office lab. It is a CLIA wave test, but no, it cannot be done by finger stick. How does the anticoagulant EDTA work to prevent the blood from clotting? It binds calcium. Remember the CEO of anticoagulants? Those are the ones that bind calcium. Name 3 things that could interfere with running this test to ruin its accuracy. Tilting of the tube, air bubbles in the tube, vibrations, incorrect timing. It's like I told you, a good way for me to show students what a abnormal sed rate looks like is to leave it sitting in that tube for longer than an hour, which you would not want to do in a real setting because that is giving you erroneous results if the blood is not fresh and extreme temperatures in your laboratory. Name 1 other disease the sed rate is used for. Other inflammatory diseases, such as rheumatoid arthritis, there's many, cancer, and leukemia. So, moving on to the pro time. What is the principle of the prothrombin time, the PT test? Okay, it measures the amount of time the blood takes to form a fibrin clot. It uses thromboplastin as the active reagent to initiate the coagulation process. Seen in this picture is the handheld point-of-care testing PT test. Now, we've talked before about how PT test is one of those tests that we normally don't use skin puncture blood on. What abnormal condition is the PT test used for? Most commonly to monitor patients on anticoagulants such as heparin, warfarin, or Coumadin. Too little blood thinners would mean a shortened PT time, could cause clots in the bloodstream and lead to a stroke or a heart attack. Also to screen for patients who lack clotting factors, have liver disease, or deficient in vitamin K, a crucial element in the production of prothrombin. So what are the names of the CLIA wave instrument used for the prothrombin time test? It's the ProTime and the CoagaCheck. How should the blood be drawn for the PT test? In a light blue top tube that must be filled 100% full. It can never be done by skin puncture. The CoagaCheck is a finger stick producing capillary blood. How are the results of the ProTime test expressed? The results are recorded in seconds and as an internal normalized ratio, INR. The INR is used to compare the results of the different methods of doing the test, whether in the physician's office lab or in the reference lab. So, talking about reference ranges and normals for the following test. Your hemoglobin, the normal range is 12 to 18 grams per deciliter. The hematocrit is 36 to 55%. The ESR sed rate is 0 to 20 millimeters per hour. And the pro time is 16 to 18 seconds or 2 to 2.5 INR. So another one of our case studies, Mr. Jack Rudolph had a heart attack. The doctor prescribed Coumadin. The doctor wanted to monitor the dose of Coumadin he prescribed. What test could be ordered to check the dose of Coumadin? The PT test. What color top tube should be drawn if sent to a reference lab? How full should it be? How full does it need to be? And what is the anticoagulant in this tube? It's light blue. It should be 100% full, and the anticoagulant is sodium citrate. If the patient's test results was 25 seconds, would this be normal? No, because 16 to 18 seconds is the normal reference range for a PT. So Troy Beckham, my neighbor's little boy, ate rat poison, which is a blood thinner. The antidote was to give him vitamin K. After vitamin K was administered, what test do you think could be run to see if enough vitamin K was given? A PT test. If sent to a reference lab, what color top tube should be drawn? How full should it be? And what anticoagulant is in this tube? Remember, guys, we learn by doing it over and over and over again. So I know sometimes these questions get mundane to you, but this is how you learn. The light blue top tube, it has to be 100% full, and the anticoagulant in that tube is sodium citrate. How would you know if Troy's blood was clotting normally? Again, compare his test results to the reference range. If he falls in between 16 and 18 seconds, then he is normal. It's normal. Is the test run in the physician's office lab usually a CLIA wave test? Yes. How should you chart a PT test? You always do the date and time first. A PT test was performed according to office procedures. The results was 16 seconds, your initials and credentials. And since it was 16 seconds and we know that's normal, then we don't need to notify our physician, nor do we need to schedule our patient for a follow-up visit. Do you have to put the specimen was received? If so, why or why not? No, you do not send the patient off, like to the bathroom, to collect the specimen and bring it back. So there's no need to put specimen was received. What if the test result was 20 seconds, which as we know is over 18 seconds, so that would be too high. How would you chart this? Do you fill in the test completed by section of the requisition form? If so, why or why not? You put the date and time as always. A PT test was performed according to office procedures. The results was 20 seconds, which is exactly the same as our one up above. Now the difference is 16 seconds is normal, 20 seconds is not. So now additionally, we need to chart that we notified the doctor of the abnormal results by saying the doctor was notified. And usually if the results are abnormal, we must get with our patient for a follow-up appointment. So you want to chart that you did schedule that, your initials and credentials. Yes, if you ran the test, then you would fill out the test completed by section of the requisition form. How should a CBC be drawn? Now we're moving on to a complete blood count. It should be drawn in a lavender or purple top tube with EDTA filled up to the top 100%. Okay? What level of test is the CBC? It's a moderately complex test. Okay? We want to be able to list the 7 tests in a CBC. Trust me, guys, this is going to be on a test. So make sure you're able to list these 7 tests that are on a CBC. Okay? First and foremost, you have your RBC count, and your WBC count, and your platelet count. So all 3 of those cells are counted. Then you have your hemoglobin and hematocrit, and your RBC indices, and then a differential count. Okay, continuing with our CBC, the question is, are the reference ranges the same for men and women, adults and children? No, they vary widely. Are reference ranges the same all over the country? No. Reference ranges vary in different parts of the country depending on different things. The altitude in a place in Colorado with lots of mountains is going to be different than the Mississippi Delta, which is very flat. If you live somewhere with moderate temperatures, it's never really too cold, it's never really too hot, that's going to be different than living in the South where in August, it's 100% humidity and 110 in the shade. These things are going to affect your CBC count, okay? So that is why CLIA requires that each lab print out their own normal values along with the test results. So here's some homework, and it's in space number 65. You guys are used to doing this. The concept is you're going to write in your own words, tell why reference ranges are not the same from lab to lab around the country. Okay, make sure your answer contains the following: that reference ranges are not the same from place to place. They differ with temperature, humidity, and altitude. And you want to explain that that is why CLIA makes each lab establish their own reference ranges. Continuing with our CBC. What is the name of the CBC run on an automated hematology instrument? It's a hemalog. What is the reference range for RBCs? These are things we need to know. We've discussed with menstruation that things are different between men and women. And usually the men's results are going to be a tad bit higher. Now, if you said 4.5 to 6, then you would cover everyone. But typically you want to pay closer attention when you're reporting these out, because with men, it can be from 4.5 to 6, and for women, it's normal at 4 to 5.5. Okay, what are the RBC indices? These are 3 mathematic ratios helpful in diagnosing the causes of anemia. So you have the mean corpuscular hemoglobin concentration, which is talking about the mean cell hemoglobin concentration used to diagnose anemia and polycythemia. Then you have the mean corpuscular volume, or the mean cell volume, which tells the size of the RBCs, and the mean corpuscular hemoglobin, or mean cell hemoglobin, which tells the concentration of the hemoglobin inside that RBC. Okay, what are the formulas for the RBC indices? The MCHC is the hemoglobin times 100 over the hematocrit, and you can see these other ones for the MCV and the MCH. You guys need to know these formulas in case you ever had to do this by hand, which could happen if an instrument's down or a computer's down or something of that nature. A good thing to do is to make sure that these are written down in some policy or procedure manual inside your laboratory, so that if you were to have some kind of instrument go down or you needed to do these calculations, you can easily pull that book out and be able to find those calculations. So we see here how this is done. The MCV, you would take your hematocrit, say it times 10 over your total RBCs. And then your MCH would be your hemoglobin, right? Times 10 over your RBCs. So study tips. The MCV and MCH have 10 times 10 on the top. The MCV has hematocrit times 10, think of PCV. And the MCH has hemoglobin times 10. It tells you what to multiply by 10, the hematocrit or the hemoglobin, okay? Because if you think about packed cell volume, remember we packed them down and we looked at it? That should be a dead giveaway that that's that hematocrit, right? And then the hemoglobin, it gives you away in the H on the MCH. And that V should give it away for you for the PCV, packed cell volume. Okay, these are just things to help you be able to memorize these so you can learn them, okay? And we know that both are over your total RBC count at the bottom. Okay, so, and then the MCHC is the hemoglobin times 100 over the hematocrit. So a study tip for that is MCHC is a bigger and different than the other two formulas. So if you realize that this is a bigger thing, the MCHC is bigger, then it'll tell you that it's completely different than your other two formulas, so you can start thinking, okay? And the number on the top is going to be bigger. So we go from 10 to 100, right? And then it's different because both the hemoglobin and hematocrit are in this formula instead of them being broken up. Okay? The hemoglobin's on top. And think of it because hemoglobin is in the name with the H, hemoglobin, right? So, what is the reference range for WBC? So it's 4 to 11, right? And then if it's high, this is why I think it's vitally important in healthcare for us to do CBC counts, because it can tell us we don't want to give antibiotics if it's not going to help. We don't want to just take antibiotics to be taking them. So if it's an increase in your white count, that usually indicates a bacterial infection. So it would be effective to give an antibiotic for that particular bacteria. If it's extremely high, that could indicate leukemia. And if it's low, that usually indicates a viral infection, which consequently an antibiotic's not going to help in that situation. So this is just a tool in our toolbox to help us be able to figure out what's wrong with our patient so that we can treat them effectively. So what is the reference range for the platelet count? It's 150 to 400, okay? So another one I'm thinking slide, okay? Consider a normal RBC count, WBC count, and platelet count. Which is the most numerous? Which is the least numerous? Okay, so think about this from your counts that I just gave you. Which one is the most numerous and which one is the least numerous? So the most numerous is RBC count, right? The least numerous is the WBC count. And that should, as we've been going through these slides and you've been looking at white cells, you'll see that one white cell and there's a bunch of red cells all around it. That kind of is a dead giveaway to you to start putting this stuff together, that there's a lot more red cells out there than white cells. Also, when you spin that microhematocrit tube down and you see in a normal person that packed red cells down at the bottom, there's a lot more of that packed red cell volume than there is of that buffy coat. So if Lakeisha Huckabee had a white blood cell count of 15,000, what would this probably mean? She probably has a bacterial infection. If Susan Taylor had a white blood cell count of 70,000, what would this probably mean? She could have leukemia. If Carla McWhinney had a WBC count of 2,500, what would this probably mean? She probably has a virus. If Susan Collins had an RBC of 2.5 million per cubic millimeter, what would this probably mean? She has anemia. If Mr. Homestead had a platelet count of 90,000, what would this probably mean? She has a low platelet count. It could be from a number of reasons. Better hold pressure longer after a venipuncture because she could continue to bleed. Okay, so identify the following types of anemia given their descriptions. Folic acid deficiency anemia, which is caused by a deficiency of folic acid. Iron deficiency anemia, tells you right there in the name, right? Caused by blood loss, which causes a deficiency in iron, such as meniscus or ulcers, okay? Hereditary spherocytosis, spear-shaped RBCs caused by a genetic abnormality. Aplastic anemia caused by destruction of stem cells in the bone marrow from toxins, okay? Another study tip, think of the bone marrow as being plastic. Aplastic anemia. Pernicious anemia caused by a decrease in vitamin B12. Study, think of precocious 12-year-old. Pernicious anemia. Let's see, sickle cell anemia. I'm sure a lot of you have heard of this. It's an inherited abnormality in the hemoglobin S. Thalassemia is a hemolytic anemia caused by inherited abnormal hemoglobin, and hemolytic anemia is caused by the destruction of RBCs. So talking about some WBC disorders, what does a rise in neutrophils indicate? Remember, we've talked about this, bacterial infections. What does a rise in lymphocytes indicate? Viral infections. These are the ways we can distinguish from bacterial and viral infections, so we will know which way we should treat our patient. What does an increase in atypical reactive lymphocytes indicate? Mononucleosis. Okay, another homework concept. So in your own words, describe how the different types of WBCs in a differential can be used to diagnose a bacterial infection, a viral infection, and mononucleosis. You want to make sure your answer contains that bacterial infections typically show an increase in neutrophils, viral infections typically show an increase in lymphocytes, and mono usually shows an increase in atypical lymphocytes. So here's another case study. Jamie Tully saw the doctor because she was running fever and had a bad sore throat. The doctor ordered a CBC and a rapid strep test and an immunology test, which a rapid test, that doesn't really sound quite right, but the rapid strep test is an immunology test. What color top tube should the CBC be drawn in? How full should it be? And what is the anticoagulant in the tube? These are case studies where you can start using the information that you have learned, because you will need to know, you will need to have memorized and learned what color top tube that CBC comes in. Is this one of those tubes that can be half full, or does it need to be 100% full? And what type of additive is in it? And if the additive is anticoagulant, what anticoagulant is it? And the reason we need to know this is because this teaches us what lab tests we can use for what tube. Because if this particular anticoagulant binds calcium, then we would never want to use that particular tube for a test that was any kind of profile or panel or a calcium test itself, or any profile and panel that had a calcium in it, because if it binds the calcium, then it would be erroneously low. Your calcium would be erroneously low if you use that. So these are reasons why we need to know this information. It's vitally important when you're out there working in the field and drawing patients' blood. So we know that the CBC will be drawn in a purple or lavender top tube. It needs to be 100% full always. And the anticoagulant that is in that tube is EDTA, right? So the rapid strep test came back negative, but the CBC showed an increased number of atypical lymphocytes. What disease do you suspect Jamie might have? Mono, because of the increased number of atypical lymphocytes. So identify the following types of leukemia given their description, okay? So AML, acute myelocytic leukemia. It's a sudden increase in immature granulocytes. Chronic myelocytic leukemia, CML, is a gradual long-term increase in immature granulocytes. Acute lymphocytic leukemia, ALL, is a sudden increase in immature lymphocytes common in children. And chronic lymphocytic leukemia is a gradual long-term increase in immature lymphocytes. So again, we're doing our case study here. Carrie Lynn Thomas, a 4-year-old female, was brought to her pediatrician because she was suddenly having constant nosebleeds and complained that her elbow and wrist joints ached. It was also discovered in the doctor's office that she was running a mild fever and had enlarged lymph glands. The doctor ordered a CBC. What color top tube should be drawn? How full should it be? And what is the anticoagulant in this tube? Purple top, 100% full, and EDTA. Okay? The results showed a WBC count of 90,000. The differential showed a large number of immature lymphocytes. What disease is the most likely cause? ALL, which is common in young children. Offices desire more CBC information than just the hemoglobin hematocrit can purchase semi-automatic hematology instruments approved as moderately complex. The instrument that you get has to be approved by CLIA to be moderately complex. Okay, so talking about these moderately complex automated hematology systems. Okay, what extra step does a lab need to take when performing moderately complex tests? First and foremost, you need to document the training of the people operating the instrument. You need to do competency testing on any of those operators. There needs to be detailed recordings of instrument calibration and maintenance. 2 levels of liquid control need to be ran every 8-hour shift or any shift that a test was run on a patient, and proficiency testing must be completed. So still talking about those moderately complex automated hematology systems, we're going to talk about the one we have in our lab, which is the QBC Star Centrifugal Hematology System. So the QB system performs a CBC by spinning down a capillary sample of blood into its various layers, red blood cells, buffy coat, and plasma. A fluorescent dye and a miniature float within the tube can stain and spread out the buffy coat of WBCs and platelets into 3 additional layers: granulocytes, non-granulocytes, and platelets. You'll see right over here to your right-hand side, that is the capillary tube that we use to collect our specimen in. And you can do this by skin puncture. And as I stated earlier, most of these physician office wave tests and even most of these moderately complex tests have their own specific collection device that you collect the specimen into and then put that device or that collection apparatus into their machine. We saw that earlier with the hemoglobin machine. It's the same thing here. So we're talking about the principle behind the Coulter counter system. The Coulter counter performs an automated CBC. Okay, blood is diluted with an electrolyte solution capable of conducting electricity. Blood cells pass through an opening or aperture in the instrument and cause a pulse or interruption, an impedance of the electrical current. The pulses are counted, analyzed, and calculated by the instrument, which produces a readout. So as you can see, okay, you have this little aperture down here that has an external electrode that's down in this water bath, right? And then the blood goes down in through here, and as it goes through there, this fluid has an electrical charge to it. And then as that cell goes through there, it disrupts that charge, and each time that happens, it can count that as a cell. There's also very rarely or outdated methods, okay? And so these are rarely used hematology devices for their description, okay? A thermopipette, a pipette used to dilute blood for a manual WBC and RBC. A separate pipette is used for each. As you can see, this tubing right here over to your right at the top, you see this black tubing that's attached to this pipette. Back in the day, you would take the other end of that pipe, one end of the tubing was connected to the pipette, the other end had a little piece on it, and you would put it in your mouth and draw mouth pipette things into here. As you can see now why this is not used. I wouldn't even say that it's rarely used. I would say that it is never used due to your exposure to breathing in or getting some type of reagent or blood possibly into your mouth. That is not something you're going to see that's being used anymore, but there was a time that it was used. Okay, and you would draw the blood in there, then you would draw a diluting solution in there, okay, too. And then there's the unipette, which you collects blood from a manual WBC, RBC, and a platelet count, okay? And there's different ones can depending on whether you're doing a WBC count or RBC count or a platelet count, okay? And we have those in our lab, and you see right here that this is the little bullet, okay, right here, and you use this to puncture a hole in this device, and there's liquid down in the bottom, right? Then you take this right here, and from a skin puncture, the capillary traction, the blood will go into this tube. You can use your finger to hold this other end like we talked about with the straw. Then as you depress this area here with your hands, it causes a suction. And then you take this, it goes down in there, okay? You let go of the pressure you've been holding, and then it will suck that blood down into there, okay? And then you gently push it, and it pushes the diluted specimen up in there, and then you go back and forth as you clean that tube out, and it gets all that blood that was in your little capillary down into this diluting. Then you can turn it over, stick it back in there regular, put the cap on it, and then it will set for the needed amount of time before you can perform that test. Now, this test you could actually do. They still do them in veterinarian offices. If your machine was down, you might have to do these manually. Very, very doubtful. They're very outdated and rarely used, but they are still on the market and they are used in some settings. So I do want you to be familiar with it. Okay? And then this, the hemacytometer, is the slide used for the manual WBCs, RBC, and platelet counts. So after it's diluted and it's set for the amount of time it needs to set for, then you can load, as you see right here, there. This is the slide right here. Here's the slide, okay? And this is what it looks like. That's the side view and the top view, okay? And then you put the cover slip right here is on there, okay? And then you take that pipette, and then you can use it to put the blood, the diluted specimen, into there on each side, okay? So you take it and you squeeze it, and you push it in there, and it goes and it fills those areas up under there. And then this is your grid that you can see under the microscope, and then you can count your cells, okay? So in summary, in this chapter, we talked about proper specimen collection for hematology testing. We talked of blood components found in bone marrow and peripheral blood and how they develop from that stem cell down to the blast cells and down. How to perform a blood smear. And we have a discussion question this week on blood smears. So you guys make sure you're looking at your discussion questions. Those are somewhat in the place of our classroom as well, and they're just helping you learn this stuff, okay? Basic principles of hemostasis, right? And we talked about wave testing, moderately complex, and hematology test, okay? All right, we talked about all this other stuff too, performing QC and CLIA wave tests. We talked about hemoglobin, hematocrit, and PT and sed rate testing, CBCs, and RBC indices, okay? So make sure you go through these videos. Watch them in order. I hope that this one gives you a much better picture of the slides so that you can use these slides to then fill out your study guides and then read your chapter. So right now, you should watch all these videos, fill out your study guides, and read your chapter, and then study for the Chapter 5 test that will be coming up soon. I'm trying to rework this tentative course calendar, but I will make sure that anytime we have a test, you get everything you need way in advance. You'll be able to study, and then I will let you know in advance when the next test is coming. Thanks a lot, guys, and have a great day.